dear Chairman, dear colleagues, first of all, I would like to thank all organizers for inviting me to be at this prestigious meeting, and also Professor Rosen Majov, who is a friend of mine, as of many colorectal surgeons I see. So we had the opportunity yesterday and today listen about rectal cancer and all the perioperative therapy, and also operations and total mesorectal excision. So everything it's more or less standardized. But also recently, since several years, we have patients who are after total neoadjuvant therapy, and there were several trials about total neoadjuvant therapy. So there is maybe a new group of patients, and not all these patients are observed only because not all of them have a complete response. So if they have not, they are operated. So is the lymph node number in a specimen independent? So every time is the same. So we have in a TNM protocol the number of 12 lymph nodes, minimally harvest of 12 lymph nodes in the specimen from rectal cancer, the same number as from colon cancer, because it came from the study of colorectal patients, and no one made a difference between colon and rectum, setting the number of 12. But this number in a specimen is not independent, because there are patient-related factors, like, for example, age of patient, because in older people there is less lymph nodes in fatty tissue around the rectum. There are also disease-related factors, because when we have a positive lymph nodes, so we have metastasis to the lymph nodes, we will have more lymph nodes in a specimen. There are also surgeon-related factors, because a surgeon more probably can do the excision of more lymph nodes, or even geography-related factors, because Asiatic surgeons will also remove lateral lymph nodes, and we, as a standard, will do total mesorectal excision. So, and also there are pathologist-related factors, because our pathologists will not do the same in the same center even. And also there are specific methods of finding lymph nodes, which are like a fat clearance method, when you dissolve the fatty tissue with alcohol or other agent, and after that you find lymph nodes. So also the perioperative treatment, radiotherapy and chemotherapy, can have an impact on the number of lymph nodes. Okay, but is the 12 lymph nodes in such a patient enough? So when we look at the meta-analysis, which was published 5 years ago, so the yield of less than 12 lymph nodes resulted in a diminished overall survival of patients. But in this analysis was only 9 papers, and these were observational cohort studies. So it's impossible to do a randomized trial in this subject. But when we look at the threshold, what should be the optimal number of lymph nodes resected? So 5 studies indicated that it may be a number different than 12 lymph nodes. All those patients, as you remember, are after pre-operative chemoradiotherapy. So someone indicated 6 lymph nodes, other 7 lymph nodes, another 8 lymph nodes, and it was not the 12 lymph nodes in this study. So it means that something's going on. And we together 9 centers from Poland, from Romania, this was Center of Professor Duta, and from Germany, made a retrospective study on our rectal cancer patients. And for this analysis, in a Barrow trial, is the name of trial, was 2,295 patients. And in these patients, these were patients who were treated with or without preoperative therapy. The median number of lymph nodes was 13. But over 40% of patients had less than 12 lymph nodes resected. So the question is, maybe the resection was bad, but it was more or less standardized. Okay, these are real-world data, but these were high-volume centers, so a standard of TME was well known. And in our centers, no fat clearance method was used to find the lymph nodes. So when we look at the factors which changed the number of lymph nodes, so when we had positive lymph nodes in a specimen, so there were more lymph nodes resected. If we have had older patients, there were less lymph nodes resected. Patients without preoperative radiotherapy had more lymph nodes resected. And surprisingly, patients in whom tumor was more than 10 centimeters from the anal verge had more lymph nodes resected. Maybe the segment of colon resected together with the rectum was longer, and this was the reason for. When we looked if the 12 lymph nodes cutoff will discriminate the survival curves, so in stage 2 it was a statistically significant difference. So those who had more than 12 lymph nodes resected survived better. The same was for stage 3 patients. When we looked at the pooled stage 2 and 3 patients, the situation was that when we looked at the patients with neoadjuvant treatment, so in the entire group, so patients, there was also a statistically significant difference between survival curves. So those with more than 12 lymph nodes survived better, but in the patients with pathological post-operative stage 2 and 3, so there was no difference with the number of 12 lymph nodes. So not always 12 is a good threshold for rectal cancer after preoperative therapy. In the literature, we also see that patients who responded for preoperative therapy had less lymph nodes, and there is no difference also between patients who had 12 lymph nodes resected or less than 12 lymph nodes resected. When we looked at the cut points in our patients, so for patients N+, the optimal cut point was 12 lymph nodes. For patients N0, only 5 lymph nodes were enough. For patients without radiotherapy, 11. For patients with any type of preoperative radiotherapy, so short course radiotherapy or chemoradiotherapy, was 8. And for patients with stage 2 or 3, was also 8. So Does it mean that the number of 12 is bad? No, not at all, because we shall have some kind of a common standard. When you look at the probability of a positive lymph nodes compared with the number of lymph nodes resected or harvested, so we can see that up to about 35 lymph nodes harvested, the probability of finding a positive lymph node rises. So it's better to harvest more lymph nodes, but after some number, we have maybe less patients and less data, or it does not make a difference. So coming back to a TNT, we have only a minimal information from TNT trials. So this is the information from the group from the United States, only 97 patients. And in these groups, in the induction arm, median lymph node harvest was 22. And in the second arm, so it was consolidation TNT, median lymph node harvest was 16. Okay, they used fat clearance, so this was not a standard lymph node dissection by pathologists, but augmented. But we see that it is also possible after total neoadjuvant therapy to have high number of lymph nodes. But there is up to now only the one study about the lymph nodes from the TNT trial from China. This was a stellar study, and those patients, one arm received a short course radiotherapy plus Capox 4 cycles preoperatively, and postoperatively another 2 cycles of Capox. In a control arm, there was a classical chemoradiotherapy, and postoperatively 6 cycles of Capox. And in both arms, the median lymph node harvest was 11. So it means that if we have patients with total neoadjuvant therapy using a standard, they used a standard histopathological methods, so we may have also diminished number of lymph nodes identified in a specimen. In this trial, when they found that there was less than 11 lymph nodes in a specimen, so they also administered to those patients additional chemotherapy. In conclusion, I would like to stress that there is a need for universal threshold for lymph nodes number in rectal cancer patients. So we cannot just divide those patients into those who had short course radiotherapy, who are older, who are younger. It may not be ideal, 12, the number of 12s may be not ideal to discriminate between patients and their survival. And we also may expect that even if we do proper surgery, we'll have less than 12 lymph nodes in a specimen. And a proper surgical technique rather than the achievement of a number 12 is the goal. Thank you very much.